Association of Fellow Gynaecologists, Mumbai, Coordinator MCGM Newborn Screening Program 2019 to 2022. His special interest is high-risk pregnancy and newborn screening. His for today topic आप बताओ.
Thank you, everybody. So, I'll not take a lot of time. We'll try to wind up as fast as possible. But this is a very important topic. I hope everybody here is ready to listen to what we have to say. Okay? And this is about born too soon. And there have been several speakers before me who have also spoke something about it. So we'll quickly move to the most important parts, which is anytime you have to talk about anything, you have to understand how problematic the situation is. Okay? So there are 15 million babies which are born, which are preterm in India, okay, across the world. Over 1 million children die due to complications of preterm. And preterm birth is increasing every day by day in all the countries across the world. And prematurity is the leading cause of neonatal deaths. So this is the kind of situation and the problem that we are seeing across India. Okay. And if you look at this chart, this is called as the disability adjusted life. So for example, if you have maybe period pain or if you have a migraine and because of that you cannot work, so that becomes a disability day. So if you have similar number of disability days, then that number of days are reduced from your life. And that's how we calculate, because if you want to go at macroeconomics, if you want to go understand how a public health decisions are made, you have to understand which disorder is really going to be troubling the country or the world as a whole. And in that, what tops the chart is neonatal disorders. Okay, and this has been from 1990 to 2019. So this has just not changed. Only the percentage has changed from 8.6 to 7.3. Now let's see what the India story is. The India story is, which you can see here. So this is the India story, and if you see, this is dark blue. So dark blue puts India somewhere in the range of 10 to 15 births. And out of the top 5 countries, Bangladesh, Malawi, Pakistan, and in 4th number is India. So we have almost 13% of preterm births. Okay. And among the numbers, now if you just convert this 13% into numbers, it's an astonishingly large number. It's almost 3 million babies are born too soon in India. And the way to tackle this is only that if you have to focus on the 5 E's, that is equity and rights, economic protections, environment, education and emergencies. Now just to give you a short idea of what this means is, if you give rights to women to decide what they need to do, if you give them the funds and the commercial and the economic advantage, you give them the right environment for the babies to survive, you educate them so that they know how many children to have, how much spacing it needs to do, and you manage for the emergencies. So when the baby is born, how do you really transport this? So this is the 5 E's, these are very important. Only when you address all these 5 E's, what you can do is change this whole scenario. So coming to the topic of the day, which is preterm labor, prevention and management. So as we all know, preterm labor is anything where the baby is delivered or the labor pain starts before 37 weeks of gestation. And if you have to further classify into it, you have to just divide it into less than 28, 28 to 32 and 32 to 37. So less than 28 is extreme preterm, 28 to 32 is very preterm, and 32 to 37 is moderate or late preterm. And why is this classification important? Because depending on the kind of gestation, you would see the different complications which would happen. And when you look at preterm complications, what are the 2 most important things that you see? As far as the mother is concerned, you see BPH, and as far as the child is, respiratory distress syndrome and developmental delays. So these are the 2 most common problems that we see. And if you have to understand the causes and prevention, you have to realize that education is one of the most important keys, followed by risk factor assessment. So you need to really understand whether this woman is going to go into a preterm labor or not. And once you realize that, you have to do early intervention, because only when you follow these 3 things, you are going to reduce the incidence of preterm. So coming to maternal education. So what is the maternal education that we are talking about? One is preconception care. So there are education regarding contraception, how when not to have children, using the right contraceptives, that's important. Nutrition. we have been just heard Dr. Preeti Kumar talk about anemia. Okay. The biggest problem in India, we are looking at anemia. So the right nutrition is also very important. And then sexual health problems, that is sexually transmitted disease and other issues. So preconception care.
Please maintain silence. अंशु तुम कहाँ से चाय लेके आ रही हो, सबको चुप कराओ.
So I think this was education. Okay. So basically what we have to do is preconception care is including access to family planning to adolescents, after birth through reproductive years, assessment and treat low nutritional status prior to conception and early pregnancy, and sexual health problems aimed at prevention, treatment of infections prior to and during pregnancy. And typically like malaria, genital tract infections, asymptomatic bacteriuria. So then the maternal factors, age. Okay, very simple thing. What we are seeing, just a couple of days back, I had one patient who just got married at the age of 34. Now when you get married at the age of 34, you are planning child maybe 3 months or 4 months down the line, she'll practically become 35, right? And that is going to be another question. So older age, I'm sure all the infertility specialists around here who have been managing these older pregnancies, we will vouch for it that we see more number of preterm babies happening because the age factor. So understanding the socio-economic status, understanding the how the society is moving, how the society is thinking forward, that's factor. So this is another thing which we need to address, and this is not going to be addressed by academicians, but this is going to be addressed more by changing the way how a society thinks. More number of pregnancy which happen together, twins, triplets, a lot of it is attributed to the kind of IVF treatment. Why again IVF? Again if you go back, it's age. Okay, so age increase, it causes more of IVF requirements lead multiple gestations. And the last is the previous preterm, the instances of previous pregnancy loss. The fetal factors, infections, touch infections, then you have rubella. So these are all the other infections which can cause preterm births, placental abruption and congenital anomalies. And lifestyle factors. A lot of it is important on the kind of stresses that you take. A lot of stress, you take a lot of EMI, you are working at office, at home. So you have problems in your family, immediate families, maybe separations. So all those things lead to a lot of stress. Smoking. We have seen a lot of women smoking. At some point of time, we never used to ask these questions to women, do you smoke or not? But I think now we need to realize that the younger women, we need to ask them every time, do you smoke or not? Because they need to see smoking. Because if you don't see smoking, the preterm births definitely go up. And what we don't talk about is pollution. So we need to address all these issues. So how do we identify the women at risk? First thing is the measurement of the cervical length. Okay, so when we measure the cervical length between 18 and 24 weeks, it will tell us whether the possibility of preterm is high or not. And there is another test which is available, is fetal fibronectin, unfortunately not very easily available in India. So because it is not available, we will typically focus on what is the cervical length measurement and how do we really go about it. So very important 3 points, it has to be done 18 to 24 weeks, maternal bladder should be empty, should be a transvaginal scan, there should be adequate magnification, and the measurement should be a straight line. So it's like a straight line. You don't take the curve of the canal and measure it. Okay. Now I'll just show you how that matters, bladder which is empty. Now this is a mother whose cervical length is 14 mm, but because the bladder is full, it appears to be longer. Okay. And this is the importance of having an empty bladder. So this is the algorithm, or this is the flowchart how you really go about managing based on the cervical length. So any asymptomatic single pregnancy with no prior history of preterm, you measure the CL 18 to 24 weeks. If it is greater than 25 mm, don't do anything, just forget it, go ahead with the routine ANC. If it is less than equal to 25 mm, you ask them to put them on daily progesterone till 36 weeks of gestation. Then weekly CL measurements. If at any time it is less than 10 mm and less than 24 weeks, you should consider cerclage. So basically, if it is more than 24 weeks, then cerclage is not indicated. So what are the management options that we have? The management options we have is tocolytics, in utero transfer, antenatal steroid prophylaxis, and max sulfate. So some of the things are already been covered in the morning. So the first thing to decide whether you need to start on tocolytics is whether you have to establish whether there is a preterm labor or not. So how do you differentiate whether it's a false labor or it's a preterm labor? So that is the most important differentiation which you have. Then the second question you have to ask, is there any contraindication in this case where we should not allow the labor to stop? For example, chorioamnitis, maybe infections is there, okay, or there is a bleeding parvaginal. So these are the indications where you not want to stop this labor, you want to let it happen. What is the gestational age? You have to have the correct gestational age, which is very important. What is the benefit of giving a maternal steroid? So is there a contraindication of not giving a steroid? Or if the steroid has already been given just a little while ago, then there may not be a reason of really trying to stop the labor. And whether you need time to do an in vitro. So if you have a facility where you don't really need to do an in vitro transfer, then does it make sense to stop the labor? But if you are in a PHC or if you are in a distant hospital where you don't have an NICU facility, the baby is maybe 28 weeks where the NICU facility is not that good enough, then you may want to transfer it to a better facility. And most importantly, ask the family, ask the woman what she wants. That's very, very, very important. Okay? So as a doctor, we may feel that this is the best thing for them, but it's very important to confide in them, ask them, really tell them what is important, and then let them make the decision as what they want to do with their life. So what is the drug of choice for tocolytics? The first drug of choice is oxytocin receptor agonist, antagonist. Okay. The second is beta mimetics. Nitrous oxide is also a good choice, unfortunately not easily available in India. And then the calcium channel blockers, nifedipine and magnesium sulfate. So the good thing is magnesium sulfate works in two ways. Now the first, second and third options, the studies have shown that they help in prolonging the labor anywhere between 48 to 7 days, 48 hours to 7 days. Okay. So if you need to do a longer prolongation, more than 48 hours, then the first three choices are good. But if the requirement is not that much, maybe it's just for the steroid, then even the 4 and the 5 are equally good. So now, what is the role of antenatal corticosteroids? So if you know that the likelihood of the delivery is going to happen within 1 to 7 days and the gestation is between 22 to 34 weeks, then you need to give a dexamethasone. Okay, please read here, it is dexamethasone, not betamethasone. Dexamethasone 6 milligrams every 12 hourly, 4 doses. That's it. This is the standard which is accepted in India. This is as per the government guidelines as well. What is the role of magnesium sulfate? So if the pregnancy is greater than 24 weeks but less than 32 weeks, then there is a possibility of getting some kind of a problem when the baby delivers preterm with the neurological side. That is why this is a neuroprotective reason why magnesium sulfate is given. The delivery should be imminent within the next 24 hours. So if it's not going to happen in the 24 hours, it's going to be 48 or something more, then you don't start Maxel. You need to know whether there are contraindications of giving Maxel. For example, myasthenia gravis, myocarditis, or cardiac conduction defects, or even a renal impairment. These are the contraindications where you don't give a Maxel. And how do you decide to give it? It's a simple thing, 4 milligram over 20 minutes IV, and the maintenance dose is 1 gram per hour IV. And you stop after 24 hours or once the baby has delivered. So after that is the time you stop. Thank you very much. I think it's just on time.